set a new healthcare agenda for women and cancer. My name's Shuli Ghosh. I'll be moderating this session, and I will be delighted to put any questions that you may have to our panelists. You'll see a Q&A box at the bottom of your screen. You can type your questions in there, and I will get to them as soon as I can. We're very lucky today to have some great speakers with us from both the public and the private sector. So they are going to be able to give us a range of perspectives on this issue. So let me introduce them to you now. And ladies, if you can just give a little wave or nod at the screen so attendees can see who we are introducing to them. So let's start with Dr. Julie Torode, Deputy CEO and Director of Special Projects for the Union of International Cancer Control. She's joining us from Switzerland. Dr. Lydia Jane-Selby, the Chief Executive of the National Health Insurance Authority in Ghana. Good to have you with us. Dr. Teresa Graham, Head of Global Product Strategy at Roche, also coming to us from Switzerland. And Ranjit Kaur, hello Ranjit, breast cancer survivor, patient advocate, and also president of the Breast Cancer Welfare Association in Malaysia. Great to see you all. So today we're going to be discussing how we can improve outcomes for women with cancer, and also how to improve things for women who look after cancer patients. Now, why are we focusing on women? Well, put bluntly, by and large, the female perspective has tended to be not taken into consideration by policy developers and decision makers outside the usual norms of reproductive and maternal health. And women, of course, are the backbone of society. I mean, they're often the main caregivers, whether that is paid or unpaid, and let's face it, largely unpaid. They often carry the burden of family and community life. And I think often that responsibility can impact on how they seek treatment, how they seek prevention, screening services, particularly, I think, in low and middle income countries. So my panelists today are going to be discussing what needs to change and what the barriers are. And of course, as we all know, one of the major barriers has been the coronavirus pandemic, which has massively impacted on how cancer patients have access to healthcare services. So what we're going to do is split the discussion into two parts. So part one is going to look at the rising incidence of cancer and how the health agenda needs to change to take into account the perspectives of women. And then the second part will look at the impact of COVID-19 on global cancer care, again with a focus on women, and also we'll ask the question whether lessons have been learned from the pandemic. So let's dive straight in. We're going to look at the current barriers that affect the health outcomes of women with cancer. I'm going to start with Julie from the UICC. The UICC very heavily involved in the global initiative to eliminate cervical cancer, which was just launched this week. Massively ambitious project. Tell us about that and the main challenges.
Well, thanks very much, Shuli. Well, it's an exciting time for cancer advocates. And in fact, for many researchers and healthcare workers who have dedicated their lives to the field of cervical and women's cancers. The first ever commitment at the global level to eliminate a cancer. So I think it's something that can energize the whole cancer community. And I think we should also, in the essence of what's changing and what needs to change, that leadership shown by Dr. Tedros and his team, and also the commitment of member states across the world. I was really pleased to see how many member states had co-sponsored these resolutions, as they're called, from all geographies. I think it's a real recognition that we need to respond to cervical cancer and the global disparities in both incidence and mortality of what is a devastating cancer. So maybe for those less familiar, let's have a quick look at that strategy. I have shared a slide with you, which I hope we can put up now. It's a public-friendly call to action, I think, a world free of cervical cancer. We have an elimination target, a threshold of 4 per 100,000 cases of cervical cancer each year. And for those that are less familiar with these statistics, that's pushing the level of cervical cancer below that of a definition of a rare cancer. This is going to be a long journey, particularly for those highest burden countries. But what I like about the strategy is that we're really taking a 10-year horizon, looking at what needs to happen between now and 2030. And these targets are really set across the life course. And that's a really strong message, I think, to engage communities. What we're saying is we need 90% coverage of HPV vaccination for all girls by age 15. We're then looking at the screening opportunity, using the HPV test to screen women by age 35 and by age 45. So we're really challenging countries to up the coverage and do at least 2 screens in the lifetime of a woman. And that makes a real big difference in her risk for cervical cancer. We can find precancers and we know how to treat them. And we can find cervical cancer itself. And if we find them early, we have a great opportunity to treat them to cure. So the third target is really following up, trying to get at least 90% of women followed up and treated. And what we have today is quite a lot of women being lost in the health system, lost in referral. So we really need to think about building those health systems. So I like the focus on coverage because it's talking about making sure all girls and women are involved in these prevention and treatment activities. It's also linked to the Sustainable Development Goals, and that's a really important issue where we're talking about universal health coverage, making sure that no one is denied access to both prevention services and treatment because of not having funds. So
can I just ask you about the reality on the ground, Julie, because it's brilliant that so many countries have signed up, and we know that cervical cancer is one of the most preventable cancers if it's caught early. But in countries, and you mentioned it there yourself, in countries with weaker health systems, it is going to be a major challenge to bring them up to the point where cervical cancer can be eradicated. So what are the main challenges do you foresee in implementing this strategy?
Well, first, I think we need a real commitment from the political leaders. It's great to sign off a strategy in Geneva, but what's happening at home? Are you taking this commitment, looking at your national cancer plan, working with experts to create a cervical cancer elimination strategy that's aligned with these targets? WHO has done some modelling on when low and middle income countries will reach elimination. I think if each country has that individual information, it really helps galvanize the community and make those plans both realistic and more feasible for implementation. But I think from my perspective, when we look at the global map of both incidence and mortality, the most important thing, and this is a global issue as much as it is a national one, is to focus on those within most need. That's the poor and marginalized communities, rural communities. They need information, they need the ability to act, and they do need to be in the front of the queue as far as getting access to these services. And they definitely are not at the front of the queue at the moment.
Just to broaden it out, Julie, from cervical cancer, because that's one of the cancers we immediately think about when we talk about women. But of course, women suffer all the same cancers that everyone does: skin cancer, colorectal cancer. What needs to change as far as global health priorities are concerned when it comes to looking at women suffering these cancers?
Well, the women's cancer, particularly breast and cervical cancer, really are the most dominant cancers driving the cancer burden, particularly if we look at sub-Saharan Africa. So I think we quite rightly can focus on these cancers. But I think one key issue, and I've been talking to a lot of advocates about this, is let's not silo the conversation, even in the cancer world. If we are talking to women and going into the community and sharing information about risk factors, about vaccination, about prevention for cervical cancer, why not also share that information for other very common women's cancers? Because one of the real challenges is actually getting that understanding of behavioural change. So we will need to focus on research in communities, work with women, and that work is starting to happen. But one of the interesting things I just heard last week with a researcher who's been working her whole life in this area, and she said, I found out from a community in South Africa that they don't have a word for vagina, that they only talk about this dirty place down there. So it's very difficult to talk about, preserving a healthy cervix if we haven't got the language for it. So we first need to empower women to start talking about their body parts and their concerns in a different way, but of course including the whole community in that.
Yeah, and that's something that UICC feels very strongly about, bringing in other sectors. And from what you've just said, education and self-awareness is a massive part of this. Excellent. Let me move on to Lydia. Lydia, good to have you with us. So first of all, the National Health Insurance Scheme in Ghana, the first national health insurance scheme to be set up in sub-Saharan Africa. It was more than 10 years ago. Tell me about that, and how successful have you been in getting Ghanaians to become part of that?
Thank you very much for having me. Yes, we started the health insurance scheme about 15 years ago, and it's well accepted, because what we had before, cash and carry, where you had to put money down before being treated, was really not acceptable in any way. So Ghanaians have bought into it. We have challenges around insurance concept of keeping yourself active rather than waiting to be sick and then registering. So that's something we're working on. But with reference to cancer, we were able to include breast and cervical cancer right from the beginning. But looking at our data, the challenge has been, one, having the right sort of protocols, uniform, standard, high quality protocols for diagnosis and treatment. The financial barriers, much as we were covering it, there were still some of the newer treatments which were not affordable for a scheme in a low middle income country.
Tell me how do you finance the National Health Insurance Scheme right now? It's subsidized by tax, isn't it?
Yes, we have a special levy, which is 2.5% on goods and services, which goes into the health insurance fund. Then formal sector workers, 2.5 percentage points of their pension goes into that. And then the informal sector, who are not formal, they pay a token premium. It isn't actuarially determined. So yes, the bulk of the money comes from this tax. We have a large exemption policy that identifies the poor, children under 18, and people over 70 are all exempt. So we hope in that way, much as they say tax is a regressive system, by having a lot of exemptions, pro-poor exemptions, those who have done research says our system is not a regressive type of system. So, but nonetheless, the income grows as GDP grows. So as we progress, we will obviously be able to cover a lot more. But right now, there are things we have to cover. And luckily for us, we've had willing partners who we've come into some kind of PPP arrangement with certain key cancer medications, which are given to us at a highly subsidized rate, which means it can be put on the formulary for the National Health Insurance Scheme, which then makes it affordable for everybody. And I think we're quite proud of ourselves in that regard. But
is it only breast and cervical cancer treatment which is covered?
At the moment, we're doing actuarial work around childhood cancers and prostate cancer. So it's an incremental thing. We don't want to collapse the scheme, but we need to gradually introduce what we can afford to make sure people get the benefit. But looking at our data, which we've looked at with our partners, for breast cancer, for instance, what we realized is that a lot of women came into contact with a healthcare professional at stage 1 and early stage 2. By the time they start treatment, we are at stage 3, stage 4. And this is where we need to deal with that, because you find that either they didn't really accept the diagnosis, there are some cultural barriers and taboos, and then even people think cancer is so expensive, I don't want to start the treatment. So we've got a lot of work to do to get around these barriers for people to understand that when we're catching you at stage 1, if you go straight into the process from there, you have a much better outcome than to dilly-dally and stage 3, stage 4. We're now trying to deal with the disease.
Are women, are they aware of what prevention services are available, what screening services are available? Are there mammograms available to everyone, even in rural areas?
No, so this is where we have quite a lot of work to do. We've got now 4 centers that are dotted around the country that give the full scope of services. But we have now set up a cancer registry. We have now really documented the protocols right at the lower levels, from manual examination, where do you go next, et cetera, to the point of mammograms, biopsies, and the rest. It's going to require a lot of education. In the African setting, female parts hold a kind of almost a sacred place.
So it's difficult to talk about them.
Not so, but even interference. If you're going to have surgery on any of these parts and things, it psychologically, it's a huge impact. And therefore, there has to be a lot of talking around it. So even the financial barriers, breaking the financial barrier may not be enough. There are other cultural barriers, and we have to work alongside all these barriers. But we believe we're getting somewhere, and we hope we've done a lot of work in the last 1.5 years, and we hope to be able to publish some data to show the improved outcomes, because that will encourage other women to get on board. There's no point in doing a good job and not talking about it. So hopefully, once we begin to show that the health insurance is just a token, $2, $3 a year, but the outcome is so good, it will encourage others to get on board. So the story must be told. Okay,
I'm going to come to Teresa next, but Julie, I saw that you wanted to add to a comment. Do you still want to say something?
I was just interested to ask Lydia a question, actually. You talked about the taxation route for funding insurance. Do you also have what we call the sin tax options of tax from tobacco, sugary drinks, unhealthy food? Is that a work stream or an income stream that is available to the insurance system?
We have discussed it, and I'm not painting Ghana as a holy country, but the money from the sin taxes at the moment don't seem to necessarily be worth going after. Smoking has really gone down. Alcohol consumption is not that much. And then the sugar may be the one area that we may look at. But yeah, we've looked at the sin taxes, and what we are going to get may not be worth the effort in chasing the payment. Thanks.
That's really interesting. I guess sugar is a problem worldwide. Lydia, thank you very much indeed for that. Let me come to you, Teresa. From a private sector perspective, how is Roche focusing on women in cancer, and how are you working to address the challenges that women face?
Yeah, thank you, Julie. I mean, it's funny the way I think you and Julie were talking about this initially, because I can actually very vividly remember the moment when it came to me that Roche really should be doing more in the area of women's cancers. And it was when I learned that more women actually die of lung cancer than breast cancer. And while that didn't necessarily, it shocked me, but it didn't necessarily really surprise me, because I think we know how hard it is to get women in to screen for breast or gynecological cancers, where there's such a well-defined understanding of the risk, that getting them in to screen for some of these other cancers is really quite a Herculean task. And the sad reality is that many times we're getting women too late into the healthcare systems when their cancers are really too far advanced to do to provide treatments that could realistically be helpful. And so I really feel like this is something we as a global society need to step up on, but that we at Roche have a particular opportunity to really potentially working with partners make a real difference for women. So to answer your question, I mean, how can we really do that as both a healthcare company and a business? And there are really sort of three key areas that for me sort of make the most sense. The first is taking a holistic approach. The second is thinking about integration, solutions that are more integrated and really address the spectrum of the entire journey that patients are on, and partnerships. I mean, you were talking about this earlier, I think, first and foremost, I think we have to think about cancer much more holistically than we have been, and really throughout a woman's life, to make sure that we're getting the best possible outcomes from early screening, early prevention, treatment of cancers like cervical cancer, like you mentioned, to much more earlier diagnosis of cancers that are so hard to detect, like ovarian, which I know I've personally lost 2 friends to. The launch of the WHO cervical cancer strategy is a real moment in time, and congratulations for this, because I think hopefully it will offer us an opportunity to really shift the paradigm and really change the dialogue. And there's a chance for that to make a really big difference for women around the world. Roche has a number of partnerships around the world with community-based organizations and country-based organizations, because I think as much as we talk about sort of the science of cancer and that being a global thing, I think we can all appreciate that the delivery and treatment of cancers is really local. And so we think it's really important for us to be leveraging our global presence to make sure that we're actually on the ground with the folks who can actually make the biggest difference for women. So things like in Brazil, we've worked and co-created with healthcare services an efficient and automated cervical cancer program under a disease management framework from screening to diagnosis, which has resulted in, to date, over 40 million women having been tested and potentially preventing almost 8,000 deaths from cervical cancer. I mean, that's something that has to happen at a local level, and it has to happen with great partnership. I think one of the most exciting things that's happening right now is how our understanding of the biology of cancer and our understanding of how technology and data can actually really inform cancer treatment is coming together. The fact that we can really finally use better data to identify high-risk populations and high-risk women faster, to get them treatment much more quickly at the right time, better technology to help women remember when they need to go in for screenings, when they need to go back in for treatments or checkups, to help them have better outcomes. That technology and that exists today in many parts of the world, and we have an opportunity, I think, to really leverage that in more meaningful ways to create more impactful routes of treatment for people. And I think that's a really exciting thing for us to think about within the healthcare system.
I know you're passionate about there needs to be a need for a new healthcare agenda. I'd like to pick up on the point about data, because data is something that both Lydia and Julie have mentioned. Lack of data seems to be one of the biggest obstacles to really understand where our healthcare services can make the biggest impact, and what are the gaps that we need to fill. Just talk us through a little bit about that, and how we could look to change that, and who can change that.
Yeah, I mean, I think this is a great question, and I think it's one, again, that as a collective, I think we really need to think differently about data. And COVID-19 in some ways is showing us some really interesting and different ways to approach the collection and the utilization of data in a really different way. But I think fundamentally, the ability for us today to collect data from the point of care, to use that data to help make sure that we're actually getting better and more precise treatments for anyone with cancer, to get them the type of targeted and precision treatment that is going to most likely present them with the better outcome, the opportunity to monitor those patients even remotely, so that we can help track and make sure that they're not experiencing symptoms or adverse events in ways that would be detrimental to their continuing treatment. Being able to get them back in faster when they do, so that we can modify treatment to help ensure that they're actually going to continue to be getting what they need in order to help slow the progression of their cancer, or hopefully cure it. But then taking all of that aggregated patient data and actually using it not only to increase the outcome of that one particular patient, but to actually look at that data at scale and figure out how we can use that to inform the treatment of other patients with similar disease, but also to inform our ability to our ability to actually research and to actually find new treatments that are better based on what we're able to see from how patients are being treated today. Not that long ago, I think we all would have thought that that's a great dream and we can do that in certain places. But I think more and more we're finding that there are countries like Ghana that are very committed to actually finding ways to make this happen. We've got a great pilot going on in Croatia right now, which had one of the worst outcomes for metastatic cancer patients in the world, and they decided that was unacceptable. And they've now put together a new data platform to help ensure that patients get better treatment. And we've been really excited to partner with them in that. But there's real opportunity to treat data differently, as long as we are all willing to, I think about care in a different way, to think about the role that we all play in healthcare in a different way. And I think that's where that partnership becomes increasingly important. But also to understand that, our understanding of biology of cancer, our understanding of how to diagnose cancer, to treat it, and the technologies available to help us do that are vastly outstripping the sophistication of most of our healthcare systems and our policy systems that allow us to do it. And so I think those kinds of conversations, which I know many of my fellow panelists are also well involved in, those are some of the issues that we have to tackle, because the technology and the biology are here today, but in many cases, the architecture of our healthcare system and our policymakers are not.
So that's
a big impediment.
Catch up with
Exactly.
what we know. Brilliant. Teresa, thank you for that. Let me bring in Ranjit. Ranjit, tell me about your experience in Malaysia of the kind of challenges that women with breast cancer face. Don't forget to unmute your microphone.
Thank you for reminding me.
There you go.
I would have spoken to myself. All right, like Malaysia, just like any other middle income or low middle income countries, actually we have issues which are psychological, intellectual, and social when it comes to women's cancers. There is this huge thing about women having to multitask as mothers, as working women, and they're always kept busy, whether it's a nuclear family or a joint family. They're either taking care of someone or they're working and then they're coming home to take care of family. So, and the other thing that we found in a number of such countries is that, like in Malaysia, there is some fatalism issue about breast cancer, that, it causes death, it brings about death. So in many low and middle income countries, we find that incidence is lower than in the Western countries, but mortality is higher. So that's where we lose out a lot. And fatalism is also a lot to do with having to see, or even having experienced or heard someone having had breast cancer and died. So in their mind, the disease is connected to death. So they're using more of their psychological, their emotional part of assessing what the disease is all about. And they're also, in terms of social behaviors, which is collective social behaviors, that everybody thinks that way. And I think Lydia also talked a little bit about the breast and cervical cancer, and any of the reproductive cancers are very much connected to psychosexual issues. That's another hindrance, that some women want to hide about it until it's far too late, and then they present at late stage. So, so I think we need to tackle the psychological, the intellectual, and the social aspects of of how these diseases are, and educate people using these three contexts. Some people understand intellectually, some people understand psychologically, some people are part of like a collective social thinking, and that collective social thinking and cultural issues are very much connected to generations of people. We are seeing younger women coming at earlier stage. We're seeing older women coming at later stage.
That's really interesting, because what you're touching on there is a community and social responsibility for the women. So women, it shouldn't be just on us to think, right, I've got to go for a screen, I've got to check my breasts. It should be something that the whole of the community, even the men around us, should be focused on our health. Is that something that the Breast Cancer Welfare Association is working to change?
Actually, we had a lot of, we had a lot of learning curves throughout the years, and we found that a number of women actually presented their breast lumps because their husband detected it.
Right.
All right. So in that way, we find that men are more using their intellectual better than the women are, because the men are looking at it from a different point of view. They're looking at it from a disease point of view. The woman is looking at it from a mortality issue point of view, or suffering, or social stigma point of view. What do people say? Have I done something wrong, or I did something wrong, or did I sexually, was I having sexual relations with somebody else before? And that is why people think I have cervical cancer. You know, those type of things people talk about. So I think that the responsibility falls on everybody else in the community as well, including employers.
But that sounds as though it should also be a government thing. Shouldn't the government be putting out some kind of public health announcement, the right way to think about breast cancer?
So my suggestion to the government is that we did very well with maternal and child health care services, because we had village clinics, and they still are there. And why can't these village clinics have special nurses handling the cancer issues with women? And they can look at early detection, because we have mostly palpable lumps by the time women come to the hospital. So maybe mammogram may not be the most cost effective, but it could be clinical breast exam, making them breast aware, getting them to keep coming back for checks and conversations and discussions when they sit in a group. There can be these influencing factors like survivors of breast cancer coming in and talking about it to the women in the village, and that I survived it. Look, I found out and I got myself treated. So it's monkey see, monkey do kind of thing, you know. But she survived it, I can survive it.
I think that's fascinating. Julie, you had something to say about that.
I just wanted to reinforce what Ranjit was saying about really trying to get this down to community level and providing the information to communities from people they trust. And I think integration of cervical cancer prevention information, but also broader cancer information, so critical at primary care level. And it's no coincidence, in fact, I would hope that it means stars are aligned, that in fact in the same resolution for the cervical cancer strategy, there is also one on primary care and also one on universal health coverage. So I do think the global health thinking is really coming together, trying to think about how we take more a holistic approach, which is great. But how do you make that happen in a community when there's one healthcare worker who is very, very busy? So I do think it's a great approach, but we need to support the local communities to really make that happen. And yeah, one of the essences of the global strategy on cervical cancer is all about integration. So bringing in at the primary care level, the community level, but also thinking about how we add on to services where women are already coming. So we have seen in some settings that reproductive health services also get more women coming if they add in cervical cancer services. So women come for the screen, but they also then take advantage of, say, the contraception services that are there. So it's a win-win. A key issue for cervical cancer, particularly in the high burden countries, is the co-infection with HIV. So how can we make sure that women living with HIV know about their increased cervical cancer risk for a start. They're 6 times more likely to progress to cervical cancer if they have HPV infection. But also, what about the service? So if someone is coming for their treatment for HIV, can they also get information about cervical cancer? Can they also get information about other women's cancers?
So that goes to the whole holistic thing that Teresa was talking about. Lydia, can I ask you that question about, because you also talked about integrating services, and there seems to be a clear connection point between when you offer services for HIV or infectious disease, that you can then bring in other services which will target cancers. Is that something that's happening in Ghana?
Well, it's something that we definitely want to work towards. The NHIS, when first set up, seemed to focus on curative. So a more passive approach to healthcare, where you sit back and somebody comes forward when they feel they need services. We need to get away from that and encourage people, the public, to almost be in a partnership with the community health workers. You can't sit back and wait for people to be sick. We have linked our health insurance now with the national ID, which is just being rolled out. So this gives us the ability to say during our claims, you have a code for cervical cancer screening. Now, if in a district you have 100 women, and over the course of the last 3 years, only 20 have had cervical screening, then the public health system can move into that district and try to find all the women and make sure that within a 5-year period, everybody between, 35 and 70 has had at least one cancer screening. So this can be done without extra, it doesn't require huge resources with what we have. It just requires to think differently and to also let the public understand they are part of the solution. We're holding out our hand, take the hand, let's work together and stop thinking about healthcare as waiting to be sick. That attitude must go. It's about staying healthy. And that's the message NHIS is trying to drive now across the country. We need to stay healthy. And that requires a more active approach to healthcare than this passive business of the worker sits back, you think you're ill, you come forward, you get treated. That is the old way. If we want UHC, we have to think differently.
Yeah, that's a totally valid point. I wanted to just pick up a little bit on this idea of targeted and precision medicine, which is something you mentioned, Teresa, about the new treatments we have. Obviously, prevention is the first step, but when it gets to the treatment stage, precision and targeted medicine, is that actually, how realistic is that in low and low middle income countries? I mean, maybe Ranjit can answer that, and I'll pick up with you then, Teresa. But in these new medicines, which have, are going to be the way we treat cancers in the future, pretty expensive. How do countries like Malaysia view those?
So ours is a higher middle income country, and
yes,
our public healthcare cost is very stretched, and there is no way that the government or the public healthcare system can cover targeted therapies because they're far too expensive. They do have for certain drugs, but they cannot afford it. We really cannot afford for the more expensive ones. The newer the drugs, the more expensive they come in. And it does get difficult for the decision makers in the public healthcare system to decide who should get it, because they cannot cover the entire population of patients who need it. And how are they going to make a decision? So that becomes a big issue. And so what some of the solutions that we've had is the co-payment system, where patients who can afford a certain amount, they co-pay for it. and part of it is covered by a private hospital or any other sort of welfare body that covers part of the payment. So sometimes it's like that. And then you have the other system where you buy two and you get one free. So there is some co-payment system, but I can't see the public healthcare system taking that big responsibility of covering the cost of targeted therapies with the kind of budget that they get. The budget really stretched, and you know, the finance ministry is not giving enough. Like Julie had just mentioned about how to get more staff to come and work in the community healthcare clinics. Even that part is stretched. I think that sometimes the lower income countries do better in terms of healthcare workers because they get school leavers, train them up in specific things and say, okay, go to the village and you cover how many houses in that village and find out, have you done your cervical cancer test? Have you done your breast check? And if you haven't, that's where you go, or we will send somebody over to do it for you. So I think something like that works better. But when your income level goes up as a country, it gets even more difficult.
Okay, yeah, because you get less help from various global bodies. I understand that.
And you have competitors among other ministries taking on more and more funds, and you get new ministries coming up with new technology and stuff like that. So you get more competitors within the government itself. So really, our healthcare system is so stretched. We are cracking our heads and scratching our heads, wondering how can we meet that need?
Maybe part of the answer is the private industry. So let me bring in Teresa and how what more can pharmaceutical companies and the healthcare private industry do to try and address this issue of you know, fantastic new treatments which make all the difference, but governments are
available but not affordable, available but not accessible, not affordable.
So I'm actually really glad that you asked this question, because I think this is the elephant in the room 9 times out of 10 when we have these conversations. And I would say, you know, a couple things on this. I mean, first of all, the most ineffective treatment is the one that never gets used, and the most expensive treatment is the one that doesn't work. So, you know, this is where I think in many cases, getting access to really good diagnostics first and foremost, to make sure that we're really understanding what kind of cancers we're dealing with and what the most effective treatments are going to be, it is in some ways one of the most cost-effective things that we can do with any system, because then you're really clear what kind of cancer you're treating, and you're treating it in the way that is going to make the best use of every dollar that we have in our healthcare system. And I think that the cost of those tests and the availability of them is coming down over time, and I think that will be hugely beneficial for the entire healthcare system. When it comes to the price of therapeutics, I mean, I think this is something that our industry has long talked about, and I think, you know, the philosophy of Roche has always been that, you know, we strive very hard to balance our ability to provide access for patients today while preserving our ability to deliver innovation tomorrow, and that's, you know, that's a delicate balance that we walk. I think we've also tried to be a leader globally in really making sure that we're pricing our products in a way that is respectful of the ability of countries to pay. So we have something that we call international differentiated pricing, IDP, where we think about what the ability of a company is to pay, and then we price our drugs differently in those areas. All of that having been said, I don't think there's any substitute for really good partnership at the local level between all of the different components of a healthcare system to ensure that as much as we can, we're optimizing for every patient and every patient's journey to make sure that that patient is getting screened as early as possible with the most sophisticated diagnostic available into a treatment that is going to have the best ability to help them. And that's something that not one part of the system can do alone. We have to do that in collaboration and partnership. And, you know, I think those partnerships are rapidly evolving over time. And I'm actually excited to see where we can go, particularly in the area of women's health, because I think there's a lot of opportunity here for us to make this a priority in parts of the world where it has never been a priority before.
Well, let me circle back to Lydia. We will be talking about the impact of coronavirus in just a moment, but I think this is a really good point for Lydia to comment on about what the silos are when it comes to looking trying to include these new types of medicine in the list of approved medicines, which are then covered by the health insurance?
Yes, it's a tricky one. I think private pharmaceutical companies have shown willing to help us add some of these medicines to our formulary. But obviously, we also have to guarantee that the medicines won't walk out of the systems, across the borders, etc., etc. So the one or two, I think there are about 3 companies we're doing this with now. We've had to set up very elaborate systems to ensure we track every vial to the patient, etc., etc. Things are getting increasingly digitized in Ghana, so we're able to, the hospitals put in the code, the patient's health insurance number, and we can really track to make sure each vial has gone to somebody within the system. When you do that, what we find is that the pharmaceutical company is willing to really make it affordable. One of the medicines, for instance, what is on the market is the IV version, but they gave us a subcutaneous version, which is a little cheaper, safer to administer in country for us, and it was more affordable. And therefore, 1.5 years into the program, we'll be able to see. The other thing Teresa mentioned is what we're doing is we're working with some of these pharmaceutical companies to also build capacity to make sure they are diagnosing properly. And we actually sat down with all the breast cancer experts and wrote up sort of diagnosing protocols and treatment protocols, which everybody will follow to give us better outcomes. And we've started the process with cervical cancer now. So once you kind of build capacity, you document, you build capacity, we're all sort of on the same path. Hopefully, we'll have better outcomes. If you have better outcomes, women will believe in the system and actually come for earlier treatment. I think that's the strategy we're trying to use here. If it succeeds, you can then replicate it to other cancers.
Excellent. Okay, we're going to move on to talk about coronavirus. I just want to pause and remind the audience that they can submit questions to any of our panelists should they wish. Let's talk about the impact of the pandemic on health services and cancer care then. Julie, I know that the UICC is part of a task force looking at this. It's fair to say that coronavirus has had a massive impact on healthcare services. What has it meant for cancer patients and their carers?
Well, I think primarily it's been a massive increase in anxiety for both cancer patients and carers, not knowing whether to stay home because they feel vulnerable or go to the clinic because they're worried about their cancer progressing. But I think we need to look at the whole system here, and we've talked about diagnostics and treatment, but we forget good treatment starts with good surgery and radiotherapy as well. And both of these services have also had to adapt to the coronavirus pandemic. We're seeing a massive delay in some surgeries to the extent that some people are talking about several years before being able to actually really come back to what was normal pre-COVID. And we do know already that some of the delays in diagnosing new patients really is leading to an expectation of a shift back to later stage disease. In the UK, for example, there's very good data to show that we can expect that now. So if that's happening in higher income countries, of course, it's happening elsewhere as well. So I think it's a real a call to think about how we can recover quickly and build resilience, in the future, so that we can help deal and work with cancer patients during future pandemics, but also work out what surgeries can continue. Radiotherapy has been a service that's adapted quite well. They've been able to continue services just recently now. Of course, they're bringing in hygiene and social distancing protocols, but they are able to continue. So it's an interesting way that we're learning what we can do, what we can't do. But I think we are seeing that cancer patients and the general public are not coming back, not coming back with symptoms that are concerning and thinking that they don't want to block the hospital, they're too busy with COVID, my cancer can wait. Well, no, it can't. And so how do we manage that? And I think we're learning a bit about that, but I think we also have a long way to go.
And it's not even just having trouble accessing a treatments. There was a campaign in the UK, and I'm sure in many other countries, saying, if you have a cough, it might not be COVID, it might not be flu, it could be lung cancer. Get it checked out, because there's this tendency for people to have a complaint or a symptom, and they think, right, the health service is too busy, or there's too many other things, I don't want to go to a doctor's surgery, and so they put off investigating what might turn out to be a cancer. Do you think we're going to see the knock-on effects of that in the future?
Yes, I think that is already anticipated, and that was what I'm referring to with the stage shift. So someone presenting with a cough might be then diagnosed at a stage 1 or 2 cancer, but if they're coming a few months later, that could already be progressing. As Lydia said, we see a rapid progression of some cancers if nothing's done, and that's what's going to be the case.
It's very worrying.
I think the silver lining that many are talking about, these silver linings, and one of them is very much this ability of telehealth, like we are talking now. I think some doctors and patients are finding that modality very beneficial. But of course, that only works when you have access to the internet, where you have this ability to converse. So again, it's the poor that are being left out of this opportunity. And we also know it's women that are being left behind in the healthcare services at the moment with COVID-19.
I definitely think we should be talking about telemedicine, and I think we should have a conversation about that. Lydia, what has been the experience in Ghana? Now, I know that you yourself have tested positive for COVID-19. Great to see that you're okay. But as a woman and as a healthcare professional, what were your concerns?
Yeah. Ghana had its first case somewhere in March, and in April it was obvious that people weren't going to the hospital. Ghana's COVID experience is a little, I think, topsy-turvy, in that we haven't had the deaths and overwhelming of the health system that people expected. Why
do you think that is?
I'm not really sure. I really don't know. And there's very much a feeling amongst the masses, if you can call it that this is a kind of a rich man's illness, those who travel abroad type of illness. The locals feel that, well, they're always in the sunshine, they bath in the sea, etc., so they can't get COVID. And those who got it first were those of us who, chief executives, ministers, members of parliament. So that perception has gone on. I must say that I had come into contact with a senior official who I heard had gone to hospital with COVID. That's why I had the test and I was positive. I didn't really become ill, so it's difficult for me to judge for other people. I share a home with my elderly mother who's going to be 85 this year. That was my panic, but she tested twice and she was negative. Nobody else in the house was positive apart from me. So I knew I picked it up at work. One thing I will say that looking at our data now, the health insurance claims utilization dropped by 35% in April. In May and June, it was still down 20%. And that is worrying because it means either people were going to hospital frivolously or we have a whole load of people who did not access care. Now, in our environment, the acute illnesses, the infections and things, people will go to hospital. You know, if you've got malaria and you're really sick or you're vomiting, diarrhea, you are likely to go. What I suspect is the hypertensives, diabetics and things who you don't really have acute symptoms, they are the ones sitting at home. So 6 months down the line, are we going to have strokes, diabetic neuropathies, retinopathy? But you know, what things are we storing up for ourselves at a later date?
That's a really good question.
Yeah, these are things we have to think about. Yeah.
And it's going to be one of those things that at some point in the future, suddenly we're going to see the ramifications of that. Teresa, how do you think coronavirus is going to impact on treating women's cancer? And also, from just picking up on what Lydia said, how long will the knock-on effects go for?
Yeah, I mean, I honestly worry that one of the most lasting legacies of COVID-19 is going to be a surge in our NCDs, and that we're going to see a lot more people showing up a lot later with you know, diseases that are far more progressed that could have been easily caught if we had seen them earlier. I mean, I think the WHO has reported 75% of countries are seeing disruption to non-communicable disease treatments. I think we hear it every time we talk to, you know, our physicians. When we talk to patients who are saying they're afraid to go into the hospital, they're afraid to go in for treatments, they're afraid to go in for regular checkups, and that is going to be, I think, pretty devastating as we go forward. And it's something that I think we need to find a way to balance the ability to get routine care done while we're managing this pandemic, or I think we're just, as a global society, setting ourselves up for something that's going to be far worse going forward. You know, I think a silver lining, and there have been silver linings to COVID in a number of different ways, and I want to talk about two of them. I mean, I think one, I'm not sure we would have been having this conversation as many times as we have over the last couple of months had we not sort of had some of the things that happened with COVID that actually have exposed just the profound gender inequity that exists in our healthcare systems, even in the most mature healthcare systems. You know, this isn't a low and middle income country problem. This is an everywhere problem that we're seeing this, and I think it's heartening to me that we're having the conversation, because having the conversation is the first step to actually doing something about it. So that makes me hopeful. But then I think there were a bunch of things we saw out of how the world reacted to COVID that hopefully can be applied to all sorts of diseases going forward, including women's cancers. First and foremost, I think there's a level of trust and willingness to have dialogue across the different parts of the healthcare ecosystem that hasn't really existed before. I don't think any of us got into healthcare because we want to make healthcare worse for people. I think we're all here because we want to make it better. We've all been touched by losing someone to a preventable illness, or someone not getting the treatment that they needed, or someone refusing a treatment because they were scared of what the outcome of that might be. And I think there's a huge opportunity for us as governments, as NGOs, as businesses, as patient groups to come together to find a different path forward in ways that really matter at the community level. And I think that's the other thing that's really become increasingly clear to me over this time period, is that we can have all the conversations we want up here, but patients get helped at the ground level. We have to find ways to help patients at the ground level in a really concrete and tangible way. And then just how I think the scientific community has reacted, right? The amount of research, the speed with which that research has taken place, the willingness and ability to share data, you know, the conversations that have happened about how to think differently about care. I mean, these are all things that I think have the ability to be utilized within our healthcare systems in different ways that could be profound if we take the nuggets from them and bring them forward. So I think there's some reasons to be hopeful.
Can I ask if there have been any substantial disruptions in drug supply networks or anything like that that might impact on research and development in the future?
So I can only speak for Roche, and the answer is no. I mean, we haven't seen any material, actually any disruptions in supply. In fact, at one point there's a sort of funny anecdote where if you looked at the Sky Tracker, you know, the thing that tracks airplanes, there was one plane in the air over the ocean, and that was a plane from one of our facilities in Germany taking drug across the pond. So you know, I think you have an industry that is dedicated to making sure that, you know, drugs get where they need to go. I think the thing that we're going to have to be conscious of, again, as a global society over the course of the next couple of years, is that we don't allow nationalism to overtake the need for global healthcare. And, you know, we need to continue to have the ability to have, you know, free-flowing scientific exchange, the free exchange of goods and people. And you know, I think it is one of the things I think we probably need to be on the watch out for as we go forward.
Cool. So I know we've got a couple of questions coming in from the audience, which is great. Let me come to Ranjit first, though, because I do want to talk about the impact of coronavirus on cancer patients. This must be a very frightening time for cancer patients, Ranjit, because not only are they dealing with a disease which is impacting massively on their lives, they've also got the social aspects of that, but now they can't see their doctors, they can't have face-to-face meetings, they perhaps had problems going in to get their treatments. How has this impacted on them?
The fear is still there, although the you know, the hospitals are allowing patients to go in, because from right at the beginning it was a bit chaotic. Even the authorities were trying to set things straight and to make sure that they could separate those cases that are COVID positive. So what our government did was to have separate facilities for anyone who had COVID, so that they don't go to the other hospitals, and anybody who needs now elective surgery goes through testing before they are allowed in for surgery. Because initially, when in some hospitals patients were allowed in, even the doctors had to go into quarantine because one patient was found to be positive. And I think that was disaster. So I would say that we have now made it more systematic. But on the other hand, you find that the response by the community, patients are afraid to go to the hospitals because they link the hospitals with coronavirus, and they just say, I don't want to go, I will wait, I'd rather wait. But what we have had is we've had a number of healthcare specialists who are allowing for patients to call them on the phone and speak to them. So at least they have that link, and they also stay in communication with us. We have every Saturday, we have a Microsoft meeting team situation where we send out a poster to everybody out in the communities, and also to our contacts, and say, anyone you know who needs help, they can join this session and they can ask us questions at the same time. We usually will have a dedicated speaker, possibly speaking something to do with breast cancer and women's cancers, but we also are open to these people answering questions if people have issues with regards to COVID. And I think that gives a way for them to communicate with someone in authority to find out what can they do about it. We also have hotlines by the government for people to call in if they have issues. So I think things are now falling into place, but still there is a huge sector in the community that is afraid to get into hospitals for treatment. And we've had patients who've come to us and said, I was diagnosed in February. We had the lockdown in March, so they never went to a hospital until August, September, or October. So they had to wait for some time before they felt safe enough to go to the hospital for treatment. And then there were those who felt that they could go to a private hospital, just get the surgery first, and then later get transferred to a public hospital for further treatment. So some did that, and in that way it sort of did not delay. But then we still have, there was one data that was published that said that about 30% women, it was found that they were delayed. That we are not going to be able to see that today, it's going to be in the long term that we're going to see the delays. So we still don't know, but we think that that is going to happen definitely, because people are hesitant to go to the hospitals, not just for women's cancers, but other diseases as well. And I think the other good thing that has happened in Malaysia is that as soon as things settled by the month of April or so, the healthcare providers, actually the health ministry informed everyone that all you need to do is just call the hospital and give them your address to make sure that your house address is correct. We will send the medication to your house. So that was being couriered to their houses. So in that way, patients felt safe. For those who were on continuous treatment, like medication that they needed on a regular basis, not just for cancer, for diabetes, for everything else.
So it's been a massive learning curve in how we deal with this and get around the problems of coronavirus restrictions. One of the silver linings which people have talked about is the pivot towards digital health, telemedicine, technology, and how that helps. We've had a question from the audience talking about, can telemedicine be used to better support, to accelerate support for women with cancer? Have we learned in how we're dealing with the coronavirus pandemic to then take those lessons and help women with cancer in terms of digital technology? Is that something that's happening in Malaysia, Ranjit? Is there more use of telemedicine?
Not yet. I think that the public healthcare system will have to put some things in place before they can start telemedicine. And the simplest form that we've had is everybody has a mobile phone, that they can use a mobile phone to communicate. So I think that's the most basic form of communication that they can do, just to speak to someone in authority and ask questions that, what can I do now? Where shall I go? And the other thing is what we've been doing is we've been helping women to be savvy with online talks, online sessions, and to learn how to use a mobile phone just to connect and to be able to see somebody in front of them, because they just come like that in front of the screen and then they say, hello.
That's like my mum. My mum still does that.
So we teach them, and we have people in the background who guide these women, and they call them and they say, do this, and we will be able to hear you and see you. So we are teaching them gradually to try and connect digitally so that they can be more savvy in order to communicate in a better way. Yeah, I think that we have to get to telemedicine. If it's difficult when you have bureaucracy in the government for them to change the system. It will take them time to change it as well.
What do any of the other panelists think about the uptick in digital technology, and whether the coronavirus pandemic is going to move us quicker towards that?
Hi, Julia. I think it has given us a sort of healthy dose of pragmatic thinking, which, for whatever reason, we hadn't progressed as much in this direction. But I don't think you can solve everything with telemedicine. And I do have significant concerns that it's the poor and marginalized communities which will further be marginalized by digital health if we're not careful. But I think it's also an opportunity to think differently. And we can see this in the cervical cancer prevention sphere. So what we have is a self-sample that women can take a sample of their cervical cells themselves in private, send that away, get a test done, get their result, and be told largely that it's a negative test, because most people get a negative result, and that's it. So one, it can be done remotely, and two, it fits better with women's lives, and three, it avoids that horrible thing, and I don't know any woman that likes having a speculum exam, and you don't need it. So that's a great move forward. And then the fact that you have a positive test I would hope give you a little bit more motivation to address some of those barriers that Lydia spoke about earlier. And what we are seeing in rural settings is already some of our members working with mobile units that have been going around and doing breast exam, now adding in those cervical cancer prevention services. So I think we will see some really good examples emerging, but we do have to be careful that those services are really focused at the women most at risk, and particularly in the case of cervical cancer.
What's the situation? Sorry, did someone want to add to that? I was going to say, what's the situation in Ghana with telemedicine, Lydia? Is that something that is being looked at by healthcare professionals?
Yes, it very much is. It's on the health ministry's agenda. The private sector has taken the lead a bit more with that regard. But as has been said by others, mobile technology is very big in Ghana. Everybody has a mobile phone. So it's more mobile services reaching out to healthcare professionals, as opposed to what I consider full-blown proper telemedicine. But we are taking baby steps in that direction.
But what about this thing we were talking about earlier about the need for more support for women in certain areas like cervical cancer, breast cancer, making them more aware of what they need to look for, what they need to check, how often they need to go for screening? Is that not something that could be easily administered through mobile phone apps?
Definitely. The health insurance already sends reminders for people to renew their membership. They renew themselves on their mobile phones because everybody has a mobile money wallet on their phone, which they use. So, and the uptake is huge in the rural areas rather than the city. So they just renew their membership on their mobile phone. So yes, we can leverage on that, but the literacy rate is not so good. So not all SMS messages will be understood. We are playing with voice messages. So when it rings and you answer, it actually speaks to you in your local language to give you a message. We're playing with that as well. So I think the possibilities are endless where technology is concerned. And it's just a matter of leveraging on what the local population, it will catch their interest.
Cool. Well, I'm sure we'll talk a bit more about digital medicine. We have a question from the audience, specifically talking about flexibility in women's cancer. So what can the healthcare system do to give more flexibility, for example, choice of location of treatment in women's cancer? Unless someone wants to say, I was going to ask Ranjit, how much choice do women have once they're diagnosed in terms of how and when they can get their treatment, because women often have lots of other things to juggle and they've got to fit the treatment in with that.
So what we have seen is conversations between the healthcare specialist and the women, where when the women are told that they have got a positive finding, and then the woman might say, oh, I have got to sort things out. And usually the healthcare specialist would say, you've got this much of time. Could you come back in this number of weeks so that we can proceed with your treatment? So I think this friendly dialogue between patient and clinician is very important, where the clinician can actually allow for some open conversation and not make the patient feel threatened that this is very urgent, has to be done now. So the patient can know that she has how much time to sort things out in a family and community before she can come, because many women are in jobs that may not be formal jobs. They may be informal jobs with no contract and stuff like that, and they have to sort that out, or they're losing their income for the day when they're away. So I think that this conversation is quite good, and this actually came from earlier on when women were going for alternative remedies before coming back. I think Lydia mentioned that as well, and we still have that. But what we did was we said to the doctors, why don't you talk to them and say, okay, you want to try something, maybe you can try for two months and you come back, we'll check you again to see how it's gone, whether it's still there or it's growing, and then we can discuss further. Now that allows for the woman to feel that, yeah, I can come back here, and then feel that the doctor is supportive. I think that supportive communication is very important, and that allows for the woman that freedom to decide and to think. The other thing is, of course, if she wants the place where she wants the treatment, her choice of place of treatment, if she wants to be closer to where her children are living or somebody else is living, so that she can be transferred there. I think those are some of the local situations that we have issues with, where the doctors are more understanding today. Their communication skills are much better, and they're much more supportive in that.
I wonder whether, and I wonder whether I can ask Teresa this, because this is something you feel very strongly about. When we talk about the need for a new health agenda, are policymakers and decision makers, are they on board with this? Or is it a question of trying to get them to see things in a different way? Or are they thinking, well, if it's not broke, let's not fix it? What is the attitude?
I think it's a little bit of a mix, right? I mean, I think there are places where it's not broke, don't fix it. And then there are places where, you know, I philosophically am aligned to you, but I don't really know what to do about it. And sometimes the problem feels very big and insurmountable. But I think we're slowly and steadily starting to make progress. And the biggest part of that is just having the conversations and starting to have the data and having the opportunities to actually share with people where we can and how we can make an impact in ways that are really meaningful to populations. And I actually love the question in the chat about how do we get more of a patient voice in here, because I think the patient voice actually does make a really big difference and really resonates when you get a strong patient perspective in this mix, because I think it really resonates with all of us when you hear about the journey of someone who's been through it. So lots of progress to be made.
So let's talk about the patient voice. We have a patient advocate here. We have the UICC, which deals a lot with patient groups. How do we do we listen enough to patient voices to identify what the gaps are and what they need? And B, is that being acted upon by decision makers? What do any of the panelists think about that? Lydia.
Thank you. In Ghana, we have a lot of civil society and NGOs, but sometimes I really wonder if they truly represent the patient voice. I think I have a challenge with us not really listening to the patient voice. I'm not going to pretend. The health insurance scheme and then the service providers, the purchaser and provider, are very strong, and the members not so strong. This year, we've kind of been focusing on the members, i.e. the patient voice, but it's given through civil society organizations. And I think sometimes they owe allegiance to whoever is funding them, as opposed to the true patient voice. And until that is addressed, I'm not sure. We do surveys and customer surveys and research and things, but sometimes, yes, it is something that bothers me, that are we really hearing the true patient voice? And it is something that needs to be addressed.
Julie, what do you say to that?
Yeah, Lydia, I can completely agree with you. And it's been great actually with the launch of the global strategy and some of the meetings this week during London Cancer Week that we've had cancer patients really talk about what it means and the changes they go through as their journey progresses through diagnosis and treatment. Just yesterday, I was on a panel with someone who literally just coming out of her treatment, and that resonates so much with the audience because it's so acute and real. You know, I'm a cancer patient myself, but it was 20 years ago. You know, so I'm not quite full of the emotion that you are when you're diagnosed, and I think that's a really powerful story. And particularly when we're talking about cervical cancer, you know, I don't think many people know in high-income countries what it is like to suffer and die from cervical cancer in a low-income setting with no support, ostracized from your families in many cases, and with so much pain and suffering, and often little or no palliative care available. I cannot transport that as much as a cancer patient can. But of course, those advanced cancer patients aren't necessarily the ones that are going to get on panel discussions and attend UN meetings. So I do think we need to get that reality very close, and particularly for policymakers, they don't have time to go and look in different villages and see what the real problems are. So it is our duty as civil society organisations to do the research and bring that patient voice into these meetings. But I love, the way Lydia is always thinking about what she knows from the data she has. And that is what's going to change things. I think a powerful patient voice, along with data to show that there's actually a gap that can be addressed, that's the way we need to take this forward, because we need the local solutions that are going to work for women and communities.
Ranjit, how far do you feel that your association has access to policymakers and decision makers to put the points that are important for patients?
Yeah, we have a group, sort of like a coalition of NGOs where we do have patients' voices, and we do go together to state say our voice. But I would like to say that the patient voice should not be just at the policy level, it should also be at the community level, because if you want to change this issue of social stigma and reverse the high mortality, you need to educate the public. So instead of telling the public or giving them intellectual information alone, it is good to have a patient or someone who's been through treatment who said, I went through this treatment and I'm alive and I'm looking after my family, I'm working, I'm like a normal person now, but I just went through the treatment, finished it off. You need that kind of thing to reassure the public that this is not a death sentence, that one can continue to live life and has better chance if they go for early detection and timely medical treatment. So I think the educating has to be done to policymakers as well as to the community. And to the policymakers, like Julie just mentioned, it's an eye-opener. The first time that I was allowed into the Ministry of Health to sit and talk, it was an eye-opener for the healthcare specialists, because they looked at me like that, like, wow, where does she come from? So it's a bit like you need to open their minds about accepting what a lay person has to say, and be able to understand the lay person's journey that the person has gone through, and that many other women may not be as educated as I am, and they'll have difficulty, so they need to be handheld for some time. So I think that's one. And of course, if you've got patient voices at all levels within the hospital, at the policy level, in the community, and this will help to close the gap.
Yeah, Teresa, you wanted to add to that?
Yeah, I think that this has been a great discussion. And I just want to add that this really starts much, much further back in the pipeline. And that's how we study our drugs, how we understand the biology of disease, and making sure that women are adequately represented in our clinical trial populations, and that we're thinking specifically about the unique biology of women and how we're looking at and thinking about disease going forward. And making sure that that patient voice is included in how we're designing our clinical trials, and really thinking about making sure that we're paying attention to the things that are both important to patients, and that we're designing clinical trials that allow them to participate fully. And so I think that a lot of this starts very, very early on in the journey.
Okay, we've got time for one more question, and this is one about, this goes back to education and perceptions, urban myths, if you like, about how women in society can help other women understand about prevention and early diagnosis. Maybe sometimes unhelpful advice is passed on to women because it's a generational thing. So Lydia, let me ask you, because you were talking a lot about the social norms and the issues with what is seen as problems with female parts, I think you put them. How do we counter that?
I don't know if I have the answer, I have to be honest. I do think the patients, the survivors, are beginning to be a powerful voice in Ghana. There are some breast cancer survivor groups who are doing a lot of advocacy work to try to let women understand that, as Ranjit said, breast cancer does not equal death. And therefore, let's get on board, let's get treated. And they're doing some powerful work. but we also need to show the data, the outcomes, scientific evidence plus the patients talking is probably the answer. We need to break some cultural taboos around the survival of in women's cancer. And in Ghana, especially, women are the backbone of our society. We are very much a matriarchal society. And you'd be surprised that a lot of the time the woman is the breadwinner, she holds the household purse. And normally the man takes the decisions, but in reality, it's the woman. And therefore, when the woman is ill, it kind of affects the whole house, and the woman tries not to be ill. I think that's a way to put it. So the challenge is for women to be able to be bold enough to say, I am ill, I need help, I may have to step back from running the whole household and extended family situation. And that is going to take some generations, but I think we need the survivors and we need the data as a combination to change the narrative.
Excellent.
Thank you.
Okay, and I'm aware there's a couple of other questions. I think a lot of those points have been answered during the conversation. So I want to ask each of our panelists to perhaps give sort of final thoughts on what we need to do, how do we make the changes, and what are the key messages that you think we should be putting out there. So let me start with you, Teresa. Final thoughts on how do we improve health outcomes for women with cancer?
I mean, I think panels like this one today are a great start. And ultimately, at the end of the day, to really make a difference in the treatment of women cancers globally, no one of us has the entire picture. We're all pieces of a puzzle. And we have to find different ways to work together with an increased level of trust towards a shared common objective at the community level to actually meaningfully make a difference for patients. And I think the more that we can have this conversation, the more we can bring it to the forefront, the more that we can understand different perspectives and approaches, the closer we ultimately will be to a solution. Still a long way to go, but a lot of positive inklings that we're on a good path. So thank you. It was a great discussion.
It was. Ranjit, what do you want to see happen for female cancer patients and women carers? What would actually practically make a big difference?
I think we need to address the issue from three perspectives. One is psychological, the other one is social, and the third one is intellectual. You need to combine the three to educate the women. You cannot just use the intellectual part. You use data, you use to show that yes, this disease can be eradicated or this disease can be handled, but you also need to address it from their psychological point of view and from their social point of view, because it has a huge social stigma when it comes to women's cancers in most of our countries, and there is also a lot of ignorance there. So I think that you need to combine all the three and reduce fatalism. Yeah,
excellent points. Ranjit, thank you very much indeed. Lydia, what key final thoughts would you like to make?
Okay, I will talk from a purchaser point of view of health services. I really think those of us in sub-Saharan Africa and low middle income countries, we cannot just brush cancer off that it's not affordable. Step by step, there are things we can start doing now to decrease the cancer burden. It should not be out of our range. It's a matter of being innovative and creative in how we go about it. So I would encourage my colleagues who are in the sort of health financing space not to give up on cancer. It is doable. It's about all of us finding a way to, we can't do it all, but we can do some, and then step by step we improve it. Thanks.
Excellent. And Julie, your key takeaway and your final message.
So I may be answering the last question on the chat as well to some extent about what can we do. Well, UICC is working with a lot of its members in different countries to build coalitions using the elimination strategy as a sort of tagline. And it's bringing people who work together in the community, patient navigators, researchers, policy advocates together to really sort of have a cohesive approach of moving this agenda forward. And I encourage anyone that's working alone in a country to reach out to UICC. We're more than happy to connect you with others in your country that are working on this agenda. And particularly for the cervical cancer strategy, we're really asking our cancer partners to reach out to communities in HIV and sexual reproductive health, women's rights, even younger people. This is going to be a new generation of younger people coming through that are more cancer literate, to really start and move the agenda forward with this. But what really needs to happen, in my view, is we need a couple of big donors in this area to show how important it is and make sure that the highest burden countries can really take a step up, and they know what to do. They've got some great learnings from different countries where pilots are happening, where services are starting to expand, but we need to give those lower income countries that financial impetus to really take forward some of the great ideas that Lydia, for example, has shown today.
Excellent. Ladies, thank you very much indeed for that. I made a note of some of the key takeaways as you were talking, and from my perspective, as someone who's not involved in the cancer sphere, education, awareness, better communication, a community approach, and data. It was the one thing that kept coming up in throughout the conversation, and that's something we need to look at to improve healthcare outcomes for women and cancer. Thank you very much indeed for joining us, Dr. Julie Tarrode, Dr. Lydia Jane-Selby, Teresa Graham, and Ranjit Kaur, and thank you to the audience, to the participants for joining us and for those excellent questions which the panelists answered. And thank you to London Global Cancer Week, of course, for hosting us. Have a great rest of the weekend.